Chapter 48 discusses the drugs that affect blood coagulation. These drugs work at various steps in the blood clotting and clot dissolving processes to restore the balance that is needed to maintain the cardiovascular system. The chapter begins with a review of blood coagulation and the clotting cascade. Aspirin is an antiplatelet that is used to prevent reinfarction after the patient has experienced a myocardial infarction. Side effects include bleeding, increased bruising, and bleeding while brushing the teeth, so patients should be cautioned to use a soft bristle toothbrush while on aspirin. GI distress is another common adverse effect of aspirin, and aspirin is often given in an enteric-coated form that allows it to be dissolved lower in the digestive tract after it is passed through the stomach. Known bleeding disorders, recent surgery, or a patient who has experienced closed head injury should be given aspirin cautiously because of the increased risk of bleeding from the injured vessels. Patients who are pregnant should only be given aspirin if the benefit to the mother outweighs the risk to the fetus. Other antiplatelet agents include clopidogrel and ticagrelor. They are often given to maintain grafts and open patency of the vessel after stent placement. The route is oral. Some individuals have been found to be clopidogrel resistant. Of course, side effects include bleeding and rash. There are many drug-drug and drug-herb interactions, and I've provided an example here. If given with omeprazole, the individual may have a decreased antiplatelet effects, meaning that stent could clot. Another important consideration is because of the inhibition of platelet adhesion and the increased risk of bleeding, patients are often required to stop taking their clopidogrel or their ticagrelor 7 days before procedures such as a colonoscopy or a surgical procedure because of that increased risk of bleeding and inability to control bleeding during the surgical procedure. As with all medications, patients should be taught to understand the importance of a continued follow-up with their provider and to monitor for those adverse effects of bleeding and GI upset. Warfarin is an anticoagulant. It decreases the vitamin K clotting factors in the liver and depletes these clotting factors to lengthen the clotting time. It is frequently prescribed for patients who have experienced atrial fibrillation, and your textbook has described atrial fibrillation in a previous chapter. The adverse effect is bleeding. Warfarin also has many drug-drug interactions and drug-food interactions, particularly foods that are high in vitamin K. It is contraindicated in pregnancy, so patients who are pregnant should not be given warfarin. They will need to be given another type of drug to manage their bleeding disorder. It is an oral drug, and it takes about 3 days for the drug to become effective because remember, it has to pass through the liver, be dissolved, and then go back to the liver to be utilized appropriately. The drug also stays in the system for about 3 to 5 days after administration. It becomes very important to monitor the amount of vitamin K that is in the individual's diet and to keep that consistent. So they need to eat the same amount of green leafy vegetables every day. So if they really like broccoli and they really like kale or other green leafy vegetables, they really need to eat that same amount every day, or they need to avoid green leafy vegetables altogether. If the individual has been on heparin and is changing over to warfarin so that they can take an oral drug and be discharged from the hospital, then the individual will be kept on the heparin until their warfarin becomes at a therapeutic level, which will take about 3 days. Warfarin needs to be monitored. Levels are monitored by the PT and the INR. And the therapeutic PT-INR ratio is 2 to 3. You need to remember that. Also, patients who are on warfarin and who have a drug added that may impact the way that warfarin is metabolized will need to have their warfarin levels checked more frequently. Please also note that the antidote to warfarin is vitamin K. So the more vitamin K, the less effective the warfarin. And you can note the focus on safe administration to have this to read more about this discussion. Another anticoagulant is heparin. Heparin sodium with an antidote of protamine sulfate. So you need to remember the drugs and their antidotes. Heparin works to interfere with the clotting cascade and thrombin formation. It does not enter the breast milk, so the pregnant individual who needs an anticoagulant can safely take heparin. It prevents and treats venous thrombosis, pulmonary embolism, and is used to treat atrial fibrillation. It is also added to central lines and dialysis lines to prevent clotting of those lines. Hematologically, it can cause bleeding, and it can cause heparin-induced thrombocytopenia, both adverse effects of the drugs. Heparin can be given sub-Q and is usually given sub-Q in the hospital to prevent, as part of the deep vein thrombosis prevention package, and it can be given IV. In the IV format, it has an immediate onset. It comes in different strengths. So the heparin lock strength and the heparin injectable strengths are different. You need to be very careful and aware of which you have so that you know that you give the right amount of medication. Monitoring of the effectiveness of heparin is by the APTT, and the therapeutic level is 1.5 to 2.5, the control. And you can read more about this on page 843 in the Review of Clotting Studies chart. Low molecular weight heparins include enoxaparin. These drugs inhibit thrombus and clot formation by blocking factors 10A and 2A. They do not affect thrombin clotting or PT, so they have fewer systemic adverse effects. It's typically given to prevent DVTs, or deep vein thrombosis. Bleeding would be the major adverse reaction, and it has fewer adverse effects than heparin, and you do not use the two of these together. It is given sub-Q and typically administered in the love handles of the abdomen. It comes prepackaged, and there is a little air bolus there, and it is important not to eject the air bolus from the syringe, unlike other medications we give, because the air bubble helps push the rest of the medicine into the sub-Q tissue. A contraindication to giving a low molecular weight heparin is a sensitivity to protamine. So let's talk about the anticoagulant drugs that we've used as antidotes that we've mentioned a few minutes ago. Protamine sulfate is a strong base forms complex with heparin, and it inactivates the heparin. The dose is determined by the amount of heparin that the patient received. It is administered very slowly, not to exceed 50 milligrams in 10 minutes, but it has a quick onset to inactivate the heparin. Vitamin K, which is the antidote for warfarin, promotes the liver synthesis of clotting factors to reverse the warfarin. While some response is usually noted within 6 to 8 hours after administration, it can take up to 48 hours to see a response from the patient. So that delay of 24 hours from the time given until the changes noted in the clotting times may be related to the fact that the liver has to be stimulated to produce clotting factors. So its response to reverse the warfarin is not as quick. Chapter 49 talks about drugs that are used to treat anemias and gives a description in the beginning of the chapter of what anemia is and describes several kinds of anemia. We're going to talk about erythropoiesis stimulating agents, or epoetin alpha. which is a glycoprotein that stimulates the formation of red blood cells in the bone marrow. It's used to treat anemia in renal failure, chronic renal disease, HIV, or after chemotherapy. Major adverse effects include headache, arthralgias, nausea, vomiting, and diarrhea, and it can cause hypertension in some individuals. It can be given IV, but is typically given subcutaneously. You give the drug to get a target hemoglobin of 11 grams per deciliter, and once the hemoglobin reaches 11 grams per deciliter, then the epoetin alpha can be discontinued. One of the most common agents used to treat iron deficiency anemia is ferrous sulfate. It is used to elevate the serum iron levels and is used to treat iron deficiency anemia. Common adverse effects result from direct GI irritation. They may have GI upset, anorexia, may develop dark stools, and constipation. In the central nervous system, toxicity of ferrous sulfate can lead to seizures, coma, and death. The usual route is oral. If the drug is given as an oral liquid, the individual should take the medication using a straw to avoid staining the teeth. The medication should be taken on an empty stomach with a full glass of water or juice, because if you give it, and you may give it with a meal if the individual is having GI upset. Other routes that you can give iron include IM, the Z-track method, and box 49.5 and figure 49.4 provide you information to review the Z-track IM administration how you give it. And IV, you need to monitor the IV site for irritation. So please do review that Z-track method. You need to know how to do that. And let's also review the critical thinking scenarios on oral anticoagulant therapy, the review of clotting studies. You need to know which test it is, what it measures, and the therapeutic range that you're looking for. Therapeutic means the blood is thin enough so that clotting will not occur. So how do you know that the drug is effective? Is if it's reached that therapeutic range, not the normal range that you would expect if the drug was not in the system. Also focus on herbal meds and alternative therapies and your critical thinking scenario on iron preparations and iron toxicity.